For our emerging topics in rehabilitation assignment, Jackie and I chose to go over the female athlete triad.
During this presentation, we will define the female athlete triad, how to identify risk factors, the screening tools that you use during an evaluation, the role of the physical therapist in treating the female athlete triad, how to treat the female athlete triad, and go over some case studies.
The female athlete triad was first defined by the American College of Sports Medicine in 1992. The triad consists of low energy, menstrual dysfunction, and decreased bone mineral density. Females participating in sports have the potential of developing one or more parts of the triad. And this diagram below is showing how all three parts of the triad are connected.
Low energy availability can occur with or without an eating disorder. A small percentage of athletes have clinically defined eating disorders, but the majority fit the description of disordered eating. Disordered eating is simply defined as choosing to restrict or decrease caloric intake for various reasons, including alteration of body shape or weight, attempts to please others, or misperception that weighing less means an increased performance. A large percentage of athletes develop a negative calorie balance. About 35% of 562 female athletes from 11 Division I schools were defined as at risk for disordered eating behaviors. As a physical therapist, it's important to be aware of the clinical signs and symptoms of an eating disorder and to refer to a physician or a nutritionist if you suspect your athlete has one.
In the female athlete triad, amenorrhea is associated with exercise and defined as athletic amenorrhea. Athletic amenorrhea is a type of hypothalamic hypogonadism that is characterized by low circulating concentrations of estrogen. Amenorrhea is not a normal response to physical training, despite what many athletes, coaches, and even some clinicians claim. The primary health concerns of athletic amenorrhea are a decreased bone mineral density, osteoporosis, and increased fracture rates.
Decreased bone mineral density in female athletes is defined by the ACSM as a history of nutritional deficiencies, stress fractures, and or other secondary clinical risks for fracture together, with a bone mineral density Z-score between 1 and 2. Many athletes should display bone mineral density that is higher than the average non-athlete. Therefore, bone loss or impaired bone development in female athletes is concerning.
There are many risk factors associated with the female athlete triad, and some of them include low self-esteem, participation in sports with an emphasis on thinness or body weight, participation in sports with subjective judging, participation in sports where athletes wear revealing clothing, participation in sports with weight categories, participation in individual versus team sports, elite or very high level of competition, personality traits such as extreme dedication, compulsiveness, perfectionism, overachievement, self-critical, weigh-ins, over-controlling parent or coaches, pressure to lose weight by parents, coaches, judges, peer, or significant others, and lack of nutrition knowledge.
Some of the warning signs for the triad are wearing baggy or multiple layers of clothes, compulsive exercise outside of practice or therapy, obsessive discussion of rehabilitation, disproportional agitation, anger, fear, and anxiety regarding injury or rest, unwilling or unable to take time away from exercise, unwilling to rest or recover, another teammate has disordered eating or an eating disorder, stress fractures, slow healing or long rehabilitation time, perfectionist personality with high expectations for self, and self-critical behavior.
During the subjective portion of the exam, you can ask your patient if they have ever had a menstrual period, how old they were when they had their first menstrual period, when was their most recent menstrual period, how many periods they have had in the last 12 months, if they are presently taking any female hormones, if they worry about their weight, if they are trying or anyone has recommended that they gain or lose weight. Are they on a special diet, or do they avoid certain types of foods or food groups? Have they ever had an eating disorder? Have they ever had a stress fracture? And have they ever been told that they have a low bone density, such as osteoporosis?
Due to the prolonged interactions and length of the rehab process, we may be the first person to recognize our athlete could be at risk for female athlete triad. Despite frequent treatment of female athletes, a survey revealed that only 43% of PTs could identify all three components of the triad. Likewise, results of a similar study demonstrated that 61% of therapists stated that they knew the three components of the triad, but only 21% could actually state all of them. PTs are suited to assess the coping strategies associated with handling an injury and whether the athlete's perception of their injury is accurate. It's our responsibility to educate our patients and discuss the myths associated with the female athlete triad. Most of the treatment we will focus on in treating these athletes will be increasing their bone mineral density. Perhaps the most important aspect for the PT in dealing with the triad is prevention.
Our job as physical therapists is to educate our patients on the myths associated with the female athlete triad. One myth is that it is acceptable to follow a low carbohydrate diet or exclude foods as an athlete. In reality, low carb diets are not appropriate for an athlete and will likely result in low energy availability. Also, avoiding certain food groups such as dairy products and rich sources of iron may affect your bone health and training abilities. Another myth is thinner is better for performance. The less I weigh, the better I perform. However, being under your ideal body weight likely means that you have lost muscle mass and may not perform to your optimal abilities. A strong body is best prepared for optimal performance. Another myth is that it's okay to not menstruate. However, it is a concern if a female athlete has not had a period for 3 months or more and she needs to be seen by a physician. The last myth we will discuss is that multiple stress fractures are typical with training. In reality, this is likely your bones ineffectively dealing with stress placed on them and may be an indication of dietary or training errors. Impairment of bone remodeling is considered to be the origin of low BMD in adolescent athletes, which may contribute to the prevalence of stress reactions and stress fractures.
Now we are going to talk about how to treat the female athlete triad. Weight-bearing exercises have been shown to promote deposition of bone in female populations. Exercise with higher loads at specific targeted sites may be more effective at stimulating site-specific osteogenesis than more generally distributed loads of a lower intensity, particularly in younger women. The overload is directed toward the identified weakness. High-intensity plyometric exercises are most effective when treating these female athletes. However, if they are not being treated for the amenorrhea and disordered eating simultaneously, then no progress will be made. Trunk strengthening and weight-bearing exercises at an appropriate intensity are required to stimulate and maintain training adaptations, skeletal muscle hypertrophy, and to increase bone mineral density.
Now we are going to take a look at a few case studies. The first case study is a 20-year-old female who is an elite national caliber cross-country and long-distance track athlete on an athletic scholarship. She presents with a stress fracture of the fifth metatarsal and mid-tibial shaft with a past medical history of stress fractures. She reports 1 to 2 menstrual cycles at age 15, but has no recent memory of a menstrual period. Caloric intake is less than 1,200 kcals per day on most days. A DXA scan of the femoral neck and lumbar spine revealed osteopenia. A combination of inappropriately low body weight, inadequate caloric intake, stress fractures, and osteopenia permit the diagnosis of the triad. The PT plays a critical role in evaluating the training program. Running biomechanics and muscle imbalances were also assessed. Although muscle strength was normal in manual muscle tests, at heel strike the femur collapsed into internal rotation and adduction, with the external rotators in the hip abductors failing to adequately stabilize the femur. Consequently, a genu valgus was seen. The training program focused on dynamic lower extremity stability exercises, weight-bearing strength training, and running mechanics. Running was restricted until caloric intake progressed. As she progressed, an extensive core, including the trunk and pelvis, an upper extremity strength training program was added. As her core strength improved, so did her dynamic hip stability.
For this next case study, there was a 15-year-old female cross-country runner who presented to the PT status post open reduction internal fixation surgery for a displaced femoral neck fracture. She explained during the subjective portion of the exam that she was in pain for 4 weeks prior to the day of her injury, and her coach encouraged her to push through the pain to compete in her cross-country meet. During the meet, she heard a loud crack and fell to the ground in pain. This is an image of her x-ray. In the past, the patient had been diagnosed with medial tibial stress fractures and right hip flexor strain. She has had no menses in the past 2 years. 1 year before her injury, she lost 15 pounds due to restrictive eating. There is a family history of osteoporosis. Treatment focused on improving the patient's energy availability to resume menstrual function and optimize healing potential. At 7 months, she was pain-free with walking and low-impact activities. At 8 months, there was evidence of delayed healing on radiographs, promoting use of an external bone stimulator for 30 minutes daily. Radiographs at 12 months showed some improvement, but was not healed completely. Target of treatment was to improve her energy status through diet and exercise modifications.
Here is a list of the resources we used. I hope you guys enjoyed our presentation. Thanks.